Good evening. Good evening. I'm Jackie Reinhardt, Executive Director at SHARE. On behalf of SHARE and our program co-sponsors, JALCA and YSC, I'd like to welcome all of you to our program this evening. Conflicts of Interest in Research and Treatment, What Breast Cancer Patients Should Know. And I'd like to thank Bob Bazell for moderating this evening, and thank you to our panelists, Otis Brawley, Robert Cook-Deegen, and Fran Visco, for traveling all the way to New York City to participate in the program. I'd like to give special thanks to Helen Schiff, right over there, for her hard work in putting the program together tonight. And I'd also like to thank Actors Equity for giving this space to us. And the lab rat signs are theirs, although it kind of relates to this evening's program. It has to do with a union issue, so those are theirs. Our moderator, Robert Bazell, will start the program this evening by introducing the panelists and starting questions. Around 7 o'clock, we will open the program to the audience to ask questions of the panel. Please save your questions until that time. Robert Bazell served for 38 years as the Chief Science and Health Correspondent for NBC News. In that capacity, he earned many awards, including 5 Emmys, the Peabody Award, and the DuPont Columbia. He has also written extensively for many peer-reviewed and general interest publications and websites. Many of you are familiar with his best-selling book called HER2, The Making of Herceptin, a revolutionary treatment for breast cancer, which was adapted to a TV film. Bob is currently an adjunct professor at Yale in the Department of Molecular, Cellular, and Developmental Biology. So I'm going to turn the program over to Bob. Let's give him a big hand.
Thank you very much, Jackie, and thank you all for coming out on a cold night. Even though we're in Times Square, we get to play on Broadway, and I hope we'll all learn something very interesting. The purpose of this meeting was sparked by some articles in the New York Times, which were immediately about some researchers who did not reveal how much money they were making when they published some journal articles. But as you're going to find out, it goes much deeper than that in terms of its implications for patients and for the medical system in general. I want to introduce the panelists, all of whom I have known for a very long time, maybe longer than many of them would want to admit, but I'm honored to know all of them. To your left and my immediate right is Fran Visco, the head of the National Breast Cancer Coalition, and in my opinion, one of the most effective activists in health generally, and not just breast cancer in the nation. Next to him is Bob Cook-Deegen, who is a prominent bioethicist, who was previously at Emory University for many years, and now he's at Arizona State. He started institutes, written many papers, and given much wise advice on the subject of bioethics. On the far right is Dr. Otis Brawley, who recently resigned as scientific director of the American Cancer Society for some very good principled reasons, which we'll get into if he has time to do that. He is about to become, I'm allowed to say this now. Yeah, he's about to become chairman of a big department of oncology at Johns Hopkins. And he was previously, before he was at the American Cancer Society, he was at the National Cancer Institute, and he's always been one of the most provocative and thoughtful people that I've ever run across in my long career of dealing in oncology. So I'm going to start by asking some questions, and you'll get a chance to get in on this as well, and I hope you take advantage of it, because this is a very important issue. And the issue, as I say, doesn't just have to do with the fact that some scientists didn't tell some academic journals how much stock they own. It goes much deeper than that. But we're going to. My question for all three panelists, and we're going to go Fran, Otis, and then Bob, is what made you travel to New York and come here on this cold night to be willing to talk about this issue?
Well, I I'm here because I have enormous respect for Helen Schiff, number one. But I'm here because as a patient advocate, as an activist, as a breast cancer survivor, I recognize that the issue of conflicts of interest, it's not an esoteric issue. It's not just an academic debate. It is something that affects our lives, and lives are actually at stake. I think that this system of biomedical research and healthcare is really broken. I think it's broken at every level. I am not sure how to fix it, but I think we keep trying to tweak the existing system, and that is not going to save lives. The incentives in this system are skewed. They're skewed toward fame, and they're skewed toward profit. They are not skewed toward or focused on saving lives. The goal seems to be more and more drugs. Let's change public policy, let's change the FDA, let's get the advocacy community up in arms about approval, because we need more drugs, we need more drugs. And the focus really isn't on drugs that will save lives, it's just on more drugs. So I think the conflict of interest that we all know about, and conflicts are financial conflicts, economic conflicts, but there's also conflicts of interest that go deeper than just the money that passes hands. There's conflicts of interest in terms of relationships, in terms of wanting to be, used to be above the fold on the New York Times, wanting to be on the nightly news, getting your face out there, getting well known. But conflicts of interest result in breast cancer, certainly, in approval of drugs that just do not extend or save lives. And these drugs are incredibly costly. They're personally costly because they're costly in terms of the adverse effects of these drugs, where there's incredible risk but no or very little benefit. And they're costly in terms of the financial toxicity that accompany them. We know that, I think it was in 2013, maybe 15, the annual average cost of cancer drugs was over $207,000, and that was up from $54,000 in 1995. So the cost of drugs keep going up and up and up. And the amount of money that is at stake for all of the players in this world keeps increasing. So there are, if you look at the recent stories, so the recent stories about what happened at Memorial Sloan Kettering, and there were two big stories coming out of that institution, and that is just one institution. It's one example. It's not the only institution or the only example. So the issue of the failure of Jose Bazell to disclose his financial relationships with certain drug companies in journals was a huge issue. That was sort of the lead story. But the issue of disclosure, to me, while it is important, is not really the key issue. The key issue for me was reading about the amazing amount of money that was changing hands, the amazing amount, the millions of dollars that were involved. And as patients and as advocates, we don't focus on that. We don't even know about it. We don't think about it. When we go to see a doctor and a doctor recommends a course of treatment, we don't think about how did the evidence behind that treatment get generated. Was it good evidence? Is this something I should be taking? What's motivating this doctor to recommend this drug? What motivated the researchers to get involved in this particular trial? How were the results disseminated? How were they reported? What was the motivation behind that? We don't think about all of that. We just think about, we want our lives to be saved. We're the only ones thinking about that, I have to tell you. I think the system now is great for industry, it is great for institutions, it is great for individual clinicians, it is great for professional associations, it is not great for patients. we are at the bottom of the barrel. I think that we also need to focus a lot on exactly what conflicts exist. Again, not just financial conflicts. What are the incentives? What are the motivations? And if you look at the story about pertuzumab, which was the story covered by the New York Times, if you look at the results of the clinical trial for that particular drug, you will see that that drug was approved, and the benefit is, you'd have to squint to see how the lines part when the results of that trial were presented. Minuscule, so minimal, with significant side effects, and the results didn't even show a benefit in some of the populations. Yet, the doctor who was the subject of that particular article presented those results in a way that was different from, and spoke about those results in a way that was different from pretty much the rest of the scientific and clinical community. They were all disappointed in the results, but the person who was involved and ran the trial, and who was at an incredibly well-respected institution, and who got the most press coverage, was very positive about those results. It turns out that person had a multi-million-dollar relationship with the company. Just one example. The other information story from Memorial that was in the New York Times was the fact of the artificial intelligence company that Memorial Sloan Kettering had entered into an exclusive relationship with to create some kind of AI using our tissue. Remember, our tissue are tissue banks at the institutions where we were treated or where we had were involved in clinical trials. Those are our biological resources. Our bodies are sitting there, and institutions are now using those tissues, our bodies, to make a lot of money, to focus on profit. That is another incredible conflict of interest that, and we have no say over that. That is another amazing conflict of interest that skews what happens, who has access to the tissue, what drugs result, what devices result from that research. It's all focused on profit. The institution, Memorial Sloan Kettering, a couple of its board members, the head of the pathology department, others, have an interest in that particular artificial intelligence company. So those are the kinds of, that's just one example, one institution. Those are the kinds of conflicts that we really need to focus on, and we need to figure out how to do something about. I mean, the fact of the patents, you know, I've heard so many people say, well, I can't share these results because I'm going to patent them, because we won't be able to commercialize them unless we have a patent. And I want to say, commercialize what? You're commercializing something that isn't going to save lives. Who cares if you have a patent or not? But that's the world that we live in, and the world that we're expected to continue to raise money for, continue to give our tissue and our biological resources to support. And I think it's time to take many steps back and say, this has to stop. We have to figure out how to change it.
Excellent. Dr. Brawley.
Well, first, I'm in my 4th day as the Michael Bloomberg Professor of Ecology and Genealogy at Johns Hopkins. Why did I accept this invitation? Well, Helen Schiff called me, and I fear Helen Schiff. Fran said the system is broken. I actually truly agree with her. I grew up in the inner city of Detroit in a neighborhood where people encouraged me to go be educated and encouraged me to be curious. And I had a lot of suspicions and perhaps some paranoias because of where I grew up.
I'm sorry. Is the microphone on? Just move it a little more towards your mouth.
It's the first time in my life people have said they can't hear me. I grew up in the inner city of Detroit. I was encouraged by a number of people to be academic, to learn, and to go to graduate school, medical school. I, perhaps because of my background, was a little bit suspicious and paranoid also got sent off to be educated by the Jesuits, which gave me a good dose of skepticism. And then I got into medicine, and I should, by the way, point out, by way of full disclosure, that many of the people that you've already talked about, many of the people I suspect we're going to talk about later tonight are good friends of mine. I know their kids, I know them, and so forth. But I developed an obligation, or feeling of an obligation, to tell people the truth and try to figure out what the truth was. An obligation to the many people supported within medical school. As I got into science and medicine, I actually started realizing that there's a substantial minority of people in medicine who do not appreciate the science that they actually practice. They're people who actually don't understand the science. And it's actually easy to accept false truths when you don't appreciate the scientific truths underlying. When I say don't appreciate, I've seen people who talk about breast cancer screening and big advocates of breast cancer screening, but when I ask them questions about breast cancer, they don't know how you stage breast cancer. They don't know how you treat breast cancer. They don't know some of the fundamental concepts of screening. Lots. Big organizations, big name organizations. Found that to be true in cancer treatment as well. By the way, my specialty in medical oncology is epidemiology, looking at where the trends are going in terms of incidence and mortality, and looking at clinical trials to figure out if the clinical trial actually told you the truth, or actually told you what you were setting out to find. I also found out, actually I think it was F. Scott Fitzgerald of all people, who said it's hard to convince a man that something is wrong when he's not understanding it, when his income is dependent on his not understanding it. There are financial conflicts of interest that are many, as I'm sure you're going to talk about some more. We've already mentioned some here. I'm very concerned about what I call emotional conflicts of interest. One of the great problems in medicine is that we are very, very much rooted in our history. Keep in mind, we did the Halsted mastectomy for 50 years after Halsted died, because Halsted was from Hopkins, and he must be right. And who is any young surgeon to question Halsted? By the way, Halsted gave us the Halsted mastectomy in 1896, and finally the studies to show that it was too much surgery were published in the mid-1970s, literally, and he died in the 1920s.
Could you talk up a little bit, please?
We in medicine are really, really stuck in history and respect. We don't ask enough questions. We doctors do not ask enough questions. Although I will tell you, the American Society for Clinical Oncology has issued publications recently to say that some of these clinical trials that we're publishing nowadays that are getting drugs approved that move the median survival by 2 or 3 months really are not looking for, we're designing clinical trials not to look for big gains, and we need to start designing clinical trials to look for big gains. That I think is true, and I think that's actually a good thing about our profession. There are some good people within science and medicine who want to do the right thing. Sometimes they just have to be, it has to be pointed out to them that they have these conflicts or these other problems. And I'll yield my.
Now Dr. Cook-Deegen will give us a little bit, I think, of the history of how we got to what we're talking about.
Yeah, so the reason I'm here is the theme here is Helen, right? But in addition to that, we need your help. I think we're at an inflection point where the symptoms of a system that has been kind of running off the rails for a while, I think the symptoms are getting severe enough that we're starting to pay attention to them. when both political parties this week have introduced bills to address drug pricing, which is directly linked to the system that we're talking about. And I think we're at a point where we need to think through how to fix the system, starting from a diagnosis that Fran gave us, which is it needs fixing big time. It's producing less than we want it to produce, and it's costing way too much. And so I guess I'm hoping that we're going to think through those problems, but I also think that this system is not only broken, it's also unbelievably complicated. And I don't know a single soul on the planet who actually understands how we pay for drugs. And until and unless we understand what we're doing and actually put some sunlight into the system so that we know what's going on, I think it's going to be really, really hard to fix the system, and the law of unintended consequences will play its usual role in policy debates. So I think we need to be careful, and we need to figure out how to fix the system without destroying the good things that have come out of amazing science that's been going on for 40 years. My own history is in part in traces to the history of the Human Genome Project, which is an amazing contribution. I mean, who knew? The reason that we know that there was interbreeding between Homo sapiens and the Neanderthals and the Denisovans is because we can do DNA sequencing, something that when I was in medical school, we could not do. It was a miracle when we could stitch pieces of DNA together. So this is amazing science that's happened in our lifetime. And things like the theme that you wrote your book on, Robert, the Herceptin was an amazing, it's a miracle drug that actually made a huge difference in people's lives. Wouldn't it be nice if we kept doing stuff like that instead of these little incremental improvements that may not actually even be improvements and are costing one hell of a lot of money? So, just to set the stage on how I'm beginning to think about it, and I have to say, I don't think I know how to fix this system. We've all got ideas about how to tweak it, but I don't think, I think we're at a point where we're gonna have to think about some pretty fundamental reform. But I wanted to frame a few of the issues, because I think when we began to go off the rails, it was both a wonderful thing and a framework for how we're going to get medical innovation to happen that mainly happened in a really amazing period of science from 1975 to 1985, when a lot of stuff was happening in molecular biology, but at the national level, we were also changing the rules. So I want to take you back to 1980 and several things that happened in 1980 that I think are directly relevant to the debate we're having tonight. One is, in June of that year, the Supreme Court said you can patent living things, the famous Chakrabarty decision. Why does that matter? Well, because by the end of that year, the US Patent Office and patent offices all over the world began to issue patents on living things and molecules that are made out of biological materials like DNA and proteins. So the Cohen-Boyer patent, the famous recombinant DNA patent, happened in December of 1980. That was also the year that we came up with the term biotechnology in the way that we use it these days, which is actually invented a few blocks from here on Wall Street for people that were interested in taking advantage of the commercial opportunities that were going to grow out of recombinant DNA and cell fusion technology. And so all this stuff is happening in 1980. One other feature that happened within a week of when the Cohen-Boyer patent was issued was a law was passed as kind of a gift to a retiring senator, Birch Bayh from Indiana, who'd been trying to pass a law since 1978, and he had lost his election in the Reagan Revolution of 1980. And the opposition to his bill finally melted because, hey, let's give him what he's been working on for 2 years before he leaves the Senate. So in a lame duck session, kind of like the one we just had, they passed a bill called the Bayh-Dole statute that set up the incentives for those who get federal grants and contracts to patent the things that they develop using federally funded research and to commercialize it as the pathway to practical application. And sometimes that's a really, really good idea. What we have taken, however, is a framework that sometimes does a good job of getting things from the laboratory into practical application, and we've made it the default pathway from which it's very difficult to diverge. What we have forgotten in that process is that a lot of the really amazing biomedical innovations that happened up till that point actually happened without this pathway of commercialization. Think of the smallpox vaccination. Think of penicillin. Penicillin was not patented. It was developed by drug companies, but it was not patented. So there are ways of getting innovations into the world that don't rely on this pathway that we have made the default pathway. And it's basically the only pathway that people are thinking about these days. What's that got to do with conflict of interest? Well, we have 40 years of all of the institutions involved in biomedical innovation thinking about the way that we discover new things is we patent them, we have a startup company that develops it a certain amount of time and invests a certain amount of money, but actually can't get it all the way to the market. Somebody gobbles up that startup company, they pay a lot of money for it, and then they have to pay back the venture capitalists and everybody else who's already stacked up their expectations of revenue before they get that product to the market. So we have minnows giving rise to fish, giving rise to sharks. And that's the system that we've got. Why is it expensive? Well, it takes a lot of little fish to feed a shark. And what we've got now is we've got an ocean full of things that want to be sharks. They already are, or they want to be. And they're going to be really, really hard to keep feeding. The system of building up the little fish isn't working so well. And that's where I think we need to be thinking about policy things. The one other thing that I think is really distinctive about oncology is I think oncologists, along with cardiologists and orthopedists, set themselves up and painted themselves into a corner by having their own income depend to an unusual degree on the margin between what you pay to buy a drug and what you get paid when you administer that drug. This is not true in all parts of medicine, where you take a tablet or something like that. But a lot of the oncology drugs were administered under frameworks where the physicians themselves, their income was dependent on the use of drugs, which was, I think, it was a poison pill that the oncologist swallowed when the money was not so big, but it set up all sorts of incentives for a system that we have to live with now. And when I say that I think we're at an inflection point, I think for 40 years, we've been able to kind of figure out how can we pay for it. Yeah, it's expensive, but look, it's cancer. We'll figure out a way to do that. We'll figure out a way to pay for it. And we've been doing that for 40 years, and actually it's kind of worked. But I think we're at a point now where it is beginning to not work. And that's why I think drug pricing is the foremost health policy issue, and has been for the last 2 or 3 years. And I think for this foreseeable future, until we actually have some solutions that begin to work, it will remain one of the foremost issues. Final point is, the reason that I'm here tonight is because I think just as with cancer research in general, there are 2 constituencies that are incredibly powerful and sophisticated in the biomedical research complex. Actually, I'll say 3. 1 is AIDS activists, 2 is breast and ovarian cancer activists, and 3 is rare disease families. And I think where the wave is going to break is where those 3 constituencies focus their attention and try to come up with solutions. So I think you all in the audience here are going to be the vector that pushes the ideas that are going to turn into policy that I hope might be able to fix this broken system.
Fran, you wanted to respond to something?
Well, one thing I wanted to, well, several things I wrote down, but one thing I wanted to say was that when we talk in terms of how to pay for drugs, I don't think that's the real question. I think the real question is, how do we get drugs that work? If we had drugs that worked, then I think we can figure out how to pay for them. I don't want to figure out how to pay for all of these drugs in breast cancer that don't work and that just give people side effects and that actually some of them even kill people. I mean, if you had 3 drugs that actually cured different types of breast cancer, I think we could figure out how to reward the people who got us to that point, how to make certain that individuals in the healthcare system were protected, and we could move on. I think that is the conversation I would love to have. But I think if we just continually focus on how do we pay for these drugs, I don't think that's going to change the system that much. You know, and I also wanted to comment on the, way too many things I want to comment on, but one of the things is that there's too much money in the system. There's too much money at every level. There are too many institutions. There are too many associations. There are too many advocacy groups. There are too many scientists, too many researchers. And we just keep trying to figure out how to feed all of that, rather than say, let's wipe it all clean and figure out what should it really look like if the goal is to save lives.
Well, I hate to disagree a little bit with you, Fran. I don't think there's enough researchers out there, quite honestly. There is a problem with how we fund research, and that's actually how we fund research, how we fund medical care are somewhat interwoven, and they've gotten kind of messed up as well. If you go back 25 years ago, most of the big universities made money taking care of patients and then took some of that, which would be profit, and put it into funding research in the lab. And that's how you brought especially the young investigators into science. You robbed from the clinical side to pay for the basic side. As clinical medicine has gotten more expensive, as Medicare rules have grown, as insurances have gotten more concerned about cost, the profit in taking care of patients has gone away. And so if you're at any of the big medical institutions around the country, the administrators no longer rob from the clinical side to pay for basic science. And now at the same time, the funding of basic science from the National Institutes of Health and the National Science Foundation and so forth, that has actually gone down as well, such that it's harder and harder for young investigators especially. The average young investigator to get their first independent grant from the National Institutes of Health nowadays is 46 years old when they get their first independent grant. It's getting harder and harder. The institutions that used to fund the young investigators, like the American Cancer Society, the American Cancer Society grant pool right now is $100 million. It was $100 million in 2000, it's $100 million in 2019. It has not grown over the last 20 years. So we have science struggling to get money, can't get money from the clinical anymore. They're starting to look toward investment bankers, they're starting to look toward venture capitalists, and that's where a large amount of money that's going into developing of new drugs. Now they want to make money off of those new drugs. You've already heard a story on how a new drug which wasn't so good was actually got a great sales pitch, and I don't know how much that drug costs, probably $100,000.
It's double the cost. It's Herceptin alone is, I think, right now $74,000 a year. With pertuzumab, it's $158,000
Yeah.
or something like that.
Yeah, and so you've got some of the venture capitalists trying to make some of their money back as well. And so the system is broken. I agree with, I don't understand.
Well,
how
let me
But one thing he said is wrong.
What?
The NIH budget has grown. It has grown. I wish I had the
Oh,
graph with me. It has
it
grown.
doubled in the 1990s.
It doubled, but it has grown now with the 21st Century Cures Act. It got an incredible infusion of money, and if you look at the graph, that budget has gone up.
But when you look at.
It's just that there's
when you
more and
look-
more people trying to get pieces of it. And the question to me is, what should be funded?
No, I think
Not
that,
how many grants
I
can we
think that,
fund.
you know, the average assistant professor, in 2000 was making about $70,000 a year, but the average starting salary now is about $160,000 a year. Yes, the NIH grant budget has grown, but all costs of doing science has grown as well. And there are those indices
let me try to
that-
back this up
yeah.
a bit, because this started because of a revelation that the New York Times came up with, which didn't say much about anything, it didn't say anything was illegal, but it opened a lot of people's eyes to how much money there was in the system. You addressed the reasons for it. But this money bomb has fallen on a lot of science, but it's particularly fallen on oncology. Because these extraordinarily expensive drugs which lead to extraordinary profits. And so the question is, when the doctor comes to you as somebody who is being treated for breast cancer or anything else, or any form of cancer, what are the doctor's motivations when there are people around that doctor who are making, have stock options that may be worth many millions of dollars? And to go back to Dr. Brawley's quote, you know, when somebody's looking, they might give you the wrong information if they're looking at the bottom line. So are we looking at a system that is so broken that we have to talk about it in a way like we talk about universal health care? That we really have to think that we're at the beginning of a very long fight that's gonna go on for a long time, and we're up against powered interests that are the very same thing as the enormous wealth disparities in this country that we hear about all the time. But these wealth disparities are now taking place within medical institutions, where you have decent people who are working at a decent salary, a reasonable salary, making a good living, and then you have other people who are becoming multimillionaires, and in some cases billionaires. And do we have to stop back and say, we have to think about the impossible. We have to think about universal health care.
Well, let me just add one more thing. You need to think about, there's certain people at some of those institutions that are making a large amount of money, and then there are certain institutions themselves that are making a large amount of money. There are two problems.
Yes.
Did you add one answer?
So I was just going to observe one thing that's really interesting about oncology. If you look at the institutions that are really prominent in oncology, MD Anderson, Memorial Sloan Kettering, Fox Chase, Roswell Park, the cancer centers, these are places that took decades to reach their status of excellence, because it's really, really hard to assemble the broad expertise and everything from basic science to clinical, having access to people's who need treatment and linking that to really good science. It's a complicated thing. It took a long time to develop. These are fantastic institutions, but they are also really, really expensive and have been grafted onto this system of payment that has so many perverse incentives embedded in it, that and very few incentives for efficiency. And those institutions are largely independent of the medical schools of which they are a part.
That's true.
It's a really weird it's a weird little microcosm within biomedical research. Cancer is just really unusual because of the stakes and the advocacy and the number of grateful patients there are that support the institutions that made a difference in their lives. So that's the upside. These are fantastic institutions that do amazing stuff, and they are unbelievably inefficient. And the people at the top of those institutions do really well financially. And we have a system where you actually do need drug companies and universities and clinicians all to be working in concert. You really do. We want the system to be able to do that kind of innovation, but we have made an underlying assumption that the only way to do that is for money to be changing hands. That's everybody's just kind of framed everything as, instead of making many, many different products. One of my friends used to work for Johnson & Johnson. He said, when I started my career, we were really proud of making many, many, many products. And by the end of my career, we only made one thing, and that was money. And that's the sort of framework that this system is now a part of, where the heads of these institutions are really strongly intertwined with industry, with academe, and with clinical care. And there's big money in the clinical care and in the industry side. And actually there is in the academe too, as Fran is pointing out. NIH's $32 billion a year budget now. And the National Cancer Institute is the largest single institute of the 28 that exist at NIH. So there is a lot of money sloshing around in all three of those piles: academic, industry, and clinical care.
So I think the one question that I would have, and we're going to open up in a few minutes for all of you, but is, when a patient interacts with a physician, how does, given hearing these vast sums of money floating around, when that person says to you, you should take drug X, is it their interest, or is it, a lot of times it's the patient, because we watch the Super Bowl now and you see checkpoint inhibitors being advertised in the Super Bowl. That's an astounding thing. That there's so much money to be made in these obscure drugs that are extraordinarily complicated. And this is a part of what I used to be involved with. The media always tell us these wonderful stories of the very small percentage of people who are long-term survivors without even revealing the side effects. And so there's a lot of parts of this that need to be reoriented. And where do you start?
And I think I think it goes back further than that, because I was thinking when Otis was talking too about, I have often asked some of the most major researchers in breast cancer, why are you doing those trials? Why aren't we doing a trial that's designed to find overall survival? And the answer that I get is, you would need way too many people and way too long a time to do a trial like that. And then my question back is then, so, what you're saying then is, we do what we know how to do and can do rather than what we should do. But if we keep doing what we can do, these trials that are going to have progression-free survival, which is no clinical benefit, those are the trials that we're going to do, and then we're going to approve drugs that are going to cost $200,000 a year based on that. That is the system we built. We're never going to do trials that are looking for overall survival. So when I walk into a doctor's office and the doctor tells me to take this drug, I don't think that doctor has any financial incentive to recommend that drug to me. I think that doctor is part of a system that at the very beginning created a situation where the only thing that doctor has to give me is something that he knows or she knows probably will not save my life. So I don't think that's the right question.
Well, Fran, the doc who prescribes the drug to the average patient probably does not have this conflict of interest, except that they make money they make 6% above the average wholesale price of the drug that they prescribe. But they are influenced by people who have these conflicts of interest. By the way, real story. I started the trial, actually Bob Bazell interviewed me when I started the trial in 1992 with Ian Thompson and a bunch of people.
Excuse me, we can't hear you over here, please.
You can't hear still? Okay. All right. I started a trial in 1992, an 18,000 person drug trial. We had a finding in 2003 that was not regarding overall survival. We are publishing the overall survival results within the next month. 1992 to 2019. That's how long it takes to get an overall survival endpoint. Sometimes these overall survival endpoints are just not reasonable.
Well, but they're the only thing that should be reasonable. I mean, you're saying we should do, and maybe if you had more people, it would have taken less time. But you're saying we should do clinical trials that are not designed to find overall survival because we can get an answer more quickly, but the answer that we get is not helpful. So if we can only have 10 drugs in the world, but they, extend survival, okay, that's
Well,
okay.
The easier thing is, and this is the Emil Freyreich point. If the drug really works, you don't need a huge clinical trial to figure out the drug works. You know, when we didn't do it because we were too young, but when medical oncology cured Hodgkin's lymphoma with MOP chemotherapy, you didn't need a randomized trial. You needed about 40 patients because it was inherently a good thing.
Okay, but we don't have those.
That's right, that's right. But seriously, if you want overall survival in the drugs that we currently have, you are talking 25 or 30-year trials in the United
Still,
States.
well, what should we want if not that? What should we want if not that? We want drugs that are going to save or extend our lives. That's what we want. I understand this is a dilemma, but this is the system we've created and we've all contributed to it. We all lobby for more money for it. I mean, we all do that. I don't know how to solve that dilemma.
Well, but cancer is different. I mean, one of the initial, infectious disease drugs.
Yes.
You can see it. You could see it with Hodgkin's lymphoma because you could count the cells in the test tube. You can see that it goes away.
Yeah.
But if you can prolong the life of the average breast cancer patient by, you name the time.
Yeah.
2 days is not worth it. 6 months might be, a year might be, and cancer is a different type of disease than these other things where you don't need where you can do large simple trials.
Yeah.
There are about 20 drugs that have been FDA approved in the last 2 years, and they increase median disease-free survival usually by about 3 months. That's usually a good number.
And it's important.
Disease-free survival, not overall.
Right.
And there's a difference between disease-free survival and making the patient live longer.
Right.
She's talking about making the patient live longer.
And in that period of time, when those drugs were approved with the 3-month average survival time, the amount of money on Wall Street, you can't even begin to fathom how much money Carl Icahn just decided to get involved in biotechnology. He's about 80 years old. He owned TWA. He's a financier from a long time ago, and he decided to get involved in biotechnology investment. I heard he made something like $10 billion in the last few years. And that's the kind of money that's fallen into oncology. And it has to do with these drugs that, particularly immunotherapies, because they have these very few seemingly miraculous survivors, but they're a very small percentage. And how do you get around that? I mean, how do you get around the fact that everybody wants that shot? And I would want it, probably, if I were the patient. I can understand that. But on the other hand, if you look at it from a societal point of view, my God, are we wasting money and we're wasting effort?
Yeah, well, let's talk real numbers there. With the immunotherapies for metastatic non-small cell lung cancer, especially people who have non-small cell who smoke, they have a higher incidence of response to the immunotherapies, and you have an occasional person, perhaps 3 to 4%, who are what we call exceptional responders, meaning that there's some who are alive 4 or 5 years into therapy with nivolumab, for example, but that's a small proportion of all the people who start with nivolumab, and we don't have a test to figure out the person who's going to be the exceptional responder versus the person who's going to get the drug for 8 to 10 months at about $15,000 a month, and then we decide that drug doesn't work.
And that is the drug that's advertised one of the drugs that's advertised in the Super Bowl and other weird places where you would not expect a cancer drug to be. So at what point does society decide that for 2 or 3% genuine benefit, kind that Fran is talking about, it's worth hundreds of billions of dollars in profit for Bristol Myers Squibb. And those are one of the, yeah, tell me.
that is,
The
I mean,
ethicists. You were the
Fran-
ethicist, you tell us.
So Fran has put it, what we want is, look, we did have these miraculous things from childhood leukemia and the MOP regimen in the 60s. We had Gleevec STI 571 and Herceptin in the 1990s. Those are the sorts of things that we want, and our system occasionally produces them. It's fantastic science, and it actually saves lives. We want to do a lot more of that. But most of where this money is going is for these little tiny marginal improvements, and there is no association between the outcome increment that you get and what you pay for that outcome increment. And I think that's where, if we had a system that was working, we would have a system that says, that links the outcomes that we desire to the payment and the reward structure that the system is responding to. It doesn't do that right now.